I'll look at the MTF cycle, and in that I'll just highlight key issues. I was supposed also to share a case study, but I will not be able to do that because of time. So basically, why we are doing this, we just want to appreciate how we organize health sector at the county level. Then in terms of planning, maybe between, oh, okay, this one is not, okay. Okay, I have to confirm. So between planning and budgeting, what comes first? Do we budget first or we plan first? We plan first. Yeah, so we plan before we allocate resources. So maybe important to note to you is that one, as a CEC, you have to be very keen, and you have to take a very keen interest in terms of the county planning process. And why we are doing that as a CEC, it's your role to ensure that the plans that you are making as a county are in coherence with other county documents, because one thing that we know, we are not existing in a vacuum. We exist in another environment. So for example, while we are planning, it's your role to ensure that the plans we are making, if it's the AWP, how does it relate to the CIDP? How is it being informed by the CIDP? How is that CIDP we are preparing now as a county being linked to the vision, the bigger vision, Vision 2030? And how is the governance manifesto? The previous speaker said the CIDP is a reflection of what the governor wants to do for the next 5 years. So as we plan, how do we mirror what we are planning to do in terms of that? Then two, how to link the planning with the county, from the facility, from the community, facility, the county, and then national. How do we link the two? If I look at the CIDPs, for example, they only to talk about what the county wants to do. And we know the money that comes to the county is around 15 to 18%. The other 82% of money remains at national. How do we take advantage of that planning process to include those issues into the plan, so that now when our MPs, for example, are meeting the president to discuss how much the national government is going to invest in that county, they are referring to that in the plan. You said, for example, a dam was a priority to us as a county. Otherwise, you'll find roadside declarations or other activities or projects being initiated by national governments which are not anywhere. Somebody just comes and declares, I want to build a morgue. If you ask where it's coming from, it's not anywhere into the plan. Then in terms of timeliness, I think this is also one of the key things you have to do. As planning process has very strict timelines. And if we are supposed to do, for example, an activity by August, if we don't do it, that chance will pass us. So I think as CSCs, it's our role to ensure that the county is able to do what they are supposed to do within the time frame that is. It's just also to track the progress. It's not just about planning, but we plan, then we implement, and then we also track the progress. So as we do our work, we ensure that we are tracking what has been planned to ensure we are on track. So basically, this is just in terms of the planning, we are looking at why are we planning, where are we planning, then when are we going to do that activity, how are we going to do it, and what resources are available to actualize that plan. So in terms of the plans, we have three categories. We have short-term plans, medium-term, and long-term. So I'll start with the long-term. I said that we don't exist in a vacuum. We exist in a system. That our Bible, rather our bigger plan is Vision 2030. That's what we look up to. So as we are planning, we are referring, you look at what is happening in health, there's nothing that is not captured in Vision 2030. So our plans should reflect that as a country, as a county, we are moving towards achieving Vision 2030. Then we also refer to the Kenya Health Policy. And then the County Governments Act is so clear also. It says that we also need to do a sector plan, a 10-year sector plan for health. That's an area that I think a lot of our counties are not doing that. We only do the CIDPs. We don't do the sector plan. Then in terms of the medium plans, these are the plans that go between 3 to 5 years. We are talking of the CIDP now, the County Integrated Development Plan, the MTPs, the County Health Strategic and Investment Plans. So we also have to ensure that we are doing those plans, and we are also tracking performance in terms of reviewing. When it's, for example, in the second year, we have to track performance, review, and then move forward. Then finally, the short-term plans, which are between 1 to 2 years, we are talking about the AWPs that we do every year, the ADPs, and the budgets. So in terms of the key budgeting documents, I want to go through all of these. Basically, the County Integrated Development Plan, the Annual Development Plan, APR that was also supposed to be done annually. We are supposed to do a review of the performance. I think annually, the president is supposed to give a state of nation address, where he's saying what he or she has achieved over the year. The same way at the county level, the governor is supposed to give a state of the county address. So that instead of the county address is supposed to be informed by APR. After you review, whatever you review as a health sector is what will inform the bigger speech that the governor is supposed to present. Then the CPROP, where we're also just reviewing. Then the strategy paper, Appropriation Act, Finance, and quarterly implementation plans. I think I have to emphasize the quarterly implementation plans, or rather reports, is an area that we don't do very well as counties, and we have to inform that, because without that we can't track where we are heading. So the steps that one, we have to analyze where we are coming from. We just do a SWOT analysis and see as a county, as a department, what are our strengths, what are our weaknesses, what are our threats. And then from there, we identify the problem, and then we prioritize. I think from day one, the word prioritization has been emerging in this room, that we need to prioritize. It's one of the key things that we have to do as a sector, because we are operating in a context where the fiscal space is very limited. Then we also set objective, and then the strategic formulation. We sequence activities. We have a lot of things to do as a county, but we cannot do all of them in one day. So we have to sequence and see, out of all the things we want to do as a department, what can we do first? So we sequence and prioritize and then allocate resource. So resource allocation is also supposed to be based on the priorities, that a priority, something that is a priority to the county should get more resources. What is not a priority gets less resources. And then we action plan, and then we monitor. So before devolution and after devolution, what has changed? That one, before devolution, we had a lot of misalignment between policies and planning and action, because everything was being done centrally in Nairobi, and the level of participation was very limited. But now with devolution, we have the powers. We don't have the luxury to blame somebody else. It's now us who are at the driver's seat. Then in terms of involvement, community involvement, I can't remember during the previous regime when the community used to participate. If it used to be at either a district level or constituency. But now, the level, or rather the unit of participation is the ward, which I believe it's very much near. Then in terms of accountability, was also very, very difficult. And we normally say, if we are unable to track the county budget, if we are unable to do accountability at the county, so you can imagine what used to happen prior devolution, where we are talking of trying to track 3.1 trillion budget. It was very hard. But now with devolution, we can track the budget and all other things, because we have localized everything. In centralization of financial management, something that was before devolution. Now, with the devolution, the PFM Act also tried to centralize resources at the CRF account, but it's something that we are trying to cure. The previous speakers here were so clear that through FIF, we want to decentralize further, so that resources are at the facility level and not at the CRF. So I'll skip the others. Then this is something I'd done already, I'd mentioned. So I'll go to the next slide. This one here, where you can pay more attention to it. I think this is a summary of all the things that I've presented today. That as a county, a plan is not a linear thing, it's a cyclic. It's something that will never have a stop. So we normally plan continuously. So once the budget circular is issued, I think by 30th of August, once you issue the circular, it is your role as the CC of health to ensure that you cascade that into a department and people are able to read this and understand. So once we get the circular, the first thing that we are supposed to do is to review performance, because you cannot start planning when you have not reviewed. The challenge we have faced in most counties, when we are doing, for example, the AWP, the HRIO will take that AWP, or rather the budget. He will look how much has been allocated compared to last year. If it's an increase of 10%, he or she will put a formula of 10%. So you find in the budget from 2014, if you had an activity and a budget, that activity is recurring from FY 2014-15 up to 2021-2022. It means we are not doing zero budgeting, where we prioritize from the community, and then resources follow that. So after we do the APR, which is the annual performance review, which will inform the CPROP, we also have to do something called health forum, where we are bringing all the partners in the county just to discuss and see that the things that they are doing are aligned to the national priorities. Then the sector working group, we retreat now as a sector, we go sit down as a sector, we prioritize the things that we want to achieve in the sector, and that will inform the CFSP, which will give us the ceilings, and those ones will come from the county assembly. Once we are done with that, we do the AWP. And what I want to mention here, that AWP is one of the key documents that we need to ensure as CECs that our counties have AWPs, the annual work plan, because you cannot do anything if you don't have a work plan. So AWP is very important, and that AWP will inform what ends up into the program-based budget that is normally approved by the county assembly in June. So next I'll go to bottlenecks in planning. What have we learned? That one, there's misalignment between planning and budgeting. A lot of times people will tell you, people in health will tell you, we want to do something, but there is no money. If you ask, did you include that thing into the budget, into the plan? They say no. So if you don't participate in the planning process, it is very hard for you to get resources, because the law says that money follows the plan. We don't allocate without a plan. So basically, if you want to get money, ensure that you participate in the planning process. Then two, there is the capacity issues from the Department of Health. Either it's capacity issues, or two, unwillingness to participate. There is almost a normal assumption, an assumption that planning and budgeting function is a function of the people in finance and economic planning. So people in health will say we are not finance experts. But remember, you as a CEC, you are a political advisor to the governor on matters health. And budget making is not a technical process, it's a political process. So as a CEC, you must play your part as a politician. Otherwise, you'll be there, but you won't be able to get money. Then there's also inconsistency in terms of review and execution, where we are finding health is among the departments that where absorption is very low, and we understand the reasons why we are unable to absorb fast. If we don't do our procurement plans on time, if you are procuring commodities from KEMSA and maybe they don't have those commodities at that point, we are likely to have a low absorption capacity. And the net effect of that, once we are not able to absorb, the county assembly will do a supplementary budget and reallocate the amount. So you find we always have the highest budget, but when it comes to actual implementation, we don't have the highest budget, because you will be given 30% of the budget. After 2-3 months, you are unable to absorb. They do a realignment. They take the money to roads or other sectors. Then limited knowledge in program-based budget. I think that's also an area that a lot of counties are trying to invest in. Then finally, just limited understanding in terms of inputs needed in terms of the planning. And I'm saying, like we don't do, for example, public expenditure reviews. While we are doing reviews, we only focus on the narrative side. We will review indicators, performance, but we never review financial documents. So if we can't link the two, expenditure and narrative, then we miss the point. Then, key takeaway, that one, for us to have very good planning process, it rides, or rather it's based on good governance. So if we don't have very clear governance structures, for example, as a county, we don't have an organogram where you find people are the chief officer is reporting to accounting us. The account is where we don't have an organogram. Things are very haphazard. Once we have weak governance structures, then it means it's going to affect even our planning process, and the net effect is we get bad health. Then two, we're having financial challenges that affect budgeting, and I'd said transfers from the exchequer. I think there's somebody who mentioned, I think for 2-3 months, we haven't received the money from exchequer. And this is one of the things that is really affecting sustainability, where a partner will come and say, I'll invest this amount of money, and the county will invest this amount of money. But when the partner invests his share, when the county is supposed to invest for 2 or 3 months, the county is unable to get this share from exchequer. So the county backtracks on that. Then accountability issue, I think the Prof here said it's not about more money, but it's about more health for the money that we have. So how well are we efficient in terms of using the money that we have? Then also for planning to happen very well, we need full disclosure. You cannot plan when you don't have information. And I think a gap that we have is that we are called for 2-3 days to go and plan. You ask for baseline data, you don't find anything. If you look at our AWPs, if you look at the baseline figures, it is 0 all through. So basically we are walking a journey, but we don't know where we are coming from. So if I ask you, are you improving or not, you can't even tell. Then finally, we have to be alive that health needs are infinite, but resources are limited. So maybe a key takeaway is what I've highlighted in blue, that AWP is an implementation document and not a wish list. A lot of us, the things that we put in AWP, they're never implemented. If you ask, they'll tell you, we don't see that money. I've been in so many counties recently, and the CHMTs are complaining they don't have money. So to move around that, they want to use FIF to get money from health facilities, some percentages. A lot of the counties that are here, you have passed laws, but if you look at those FIF laws, they are saying a dispensary should raise money, but 10%, 20% of that money raised at a dispensary to save a life should go to support CHMT. If you ask why do you want to go and take money from a dispensary, which is supposed to save a mother, and go to use as a CHMT, they tell you the money that we are supposed to get from the county does not come. Then you go to the budget, you find we have a list of activities and budget allocated for CHMT activities. So I think one takeaway from here as CSCs is just to ensure that things that are in AWP are implemented the way they are supposed to be. I'm sure if we do that, we'll be somewhere. We'll achieve a lot. I think that is the end of my presentation. I welcome my friend from NHIF to do the presentation, and then we'll have a Q&A at the end.
A round of applause for Robert. I can see we are all very, very awake because that was a very nice presentation. Ladies and gentlemen, I think we are a blessed lot. Sindio? I will start counting why we are blessed. Number one, we have come for a working holiday. Watu wengi wanalipa pesa mingi sana hapo sahi. Hata kama tunatoka hapo saa moja, it's a blessing. Sindio? Christmas ni kesho kutwa, so we are just about to celebrate another holiday. Sindio? We have just been newly appointed. Niendelee kuhesabu. The PS has been here for 2 days. This is the first time that you are seeing a PS sitting in a naendelea. Niendelee. Budget nayo ni kesho kuta. Unajua I can go up to evening. Tujipigie makofi because we are blessed and God loves us. And then here we have Osoro again. This is another blessing. You know, in Betrayal in the City, it says, Francis Mbuga anasema, I like this bird for this bravery. Comes to the wrong place and doesn't even bother to keep quiet. Sasa mtu NHIF tunatafuta amejileta, but he's not. We love you. Karibu sana. So 15 minutes.
Thank you, sir. Good afternoon once again. Yeah, due to popular demand, I was told to come back today. I thought I rested our case yesterday, but as I said, to whom much is given, much more is expected. Now, what I want to do this afternoon is to try and demystify what we do at NHIF for the benefit of the newly nominated CECs, because for us to be able to appreciate where we've come from, it's good we look into the past. They say, the further you look into the past, the further you see into the future. I'll do what I call a helicopter view of NHIF. You might have noted that our vision has changed. Our current vision is to be the trusted and valued partner in securing the health of our community. And the mission is to enhance equitable and sustainable health and well-being of our community, cushioning them from financial hardships. We have a new slogan which I want to teach you today. At NHIF, we say, Afya bila stress. NHIF, are you stressed? No, you look healthy. We are here to ensure that you enjoy afya bila stress. I'll quickly do an overview of the mandate of NHIF as enshrined in the NHIF Act number 9 of 1998. The first mandate, that is part 1 to section 4 of that act, is to